The title of my project is Two Novel Mutations in the CHD7 Gene in Patients with Typical and Mild Signs of CHD Syndrome Occurring with Esophageal Atresia. My name is Evanovich, and I'm a current Master's of Science candidate at Tufts University. I'm a current Picari intern at Boston Children's Hospital under the mentorship of Dr. Evanovich, who is the principal investigator for this study. CHD syndrome presents with wide clinical symptom variability. It is a rare multi-organ genetic autosomal dominant disease known to be associated with chromodomain helicase DNA binding protein 7 gene mutations. Although CHD syndrome is associated with esophageal atresia and tracheoesophageal fistulas in 15 to 20% of cases, there are very few clinical case descriptions in the literature. In fact, a recent PubMed search revealed only 11 such cases. We present two patients with novel CHD7 gene variants with variable clinical expression of CHD syndrome co-occurring with esophageal atresia. The CHD7 gene is emerging as an important embryological regulator in the formation of the esophagus. The CHD7 gene mainly impacts neural progenitor and neural crest cells in development and affects organs populated with those cells. Animal models have shown that neural crest cells give rise to the enteric nervous system and proper development of the digestive tract. Recent human exome using mouse embryonic expression analysis suggests the CHD7 gene serves as a key component in esophageal development. We applied the diagnostics of CHD according to Sandoval and Verlois criteria to our two patients with novel CHD7 gene mutations. As you can see in the table, patient 1 had 2 major CHD anomalies and 3 minor CHD anomalies in my criteria for typical CHD diagnosis, whereas patient 2 only had 1 minor CHD anomaly and did not meet criteria for CHD diagnosis, is instead referred to as a mild phenotype. Interestingly, both patients had a point mutation in their CHD7 gene, but at different locations and with different nucleotides. Patient 1 had a point mutation from guanine to thymine at position 4644, whereas patient 2 had a point mutation from cytosine to thymine, position 4613, that was discovered to be paternally inherited and resulted in a protein change from alanine to valine at position 1538. Furthermore, patient 1 had cardiovascular malformations in addition to esophageal malformations, whereas patient 2 only had esophageal malformations. In summary, patient 1 had typical CHD syndrome, developmental delay, and a very rare type D esophageal atresia occurring in less than 1% of all patients, and required repair via direct anastomosis. Patient 2 had a mild CHD phenotype, normal neurodevelopment, and a rare type A esophageal atresia occurring in 7% of all cases and required Fokker process repair. At the time of this report, patient 1's parents had not been genetically tested, however patient 2's parents had, revealing a novel paternally inherited CHD7 missense gene variant of uncertain significance. The presented 2 novel variants in the CHD7 gene expand on the current knowledge of CHD syndrome expression. The implications are 1, the variable expression of mild CHD phenotypes from paternal inheritance in the case of patient 2 and his father calls for early genetic testing, and 2, future studies should investigate the clinical complexity of CHD syndrome in relation to esophageal atresia types and severity. Thank you very much for your attention. I'm happy to take any questions now.